With Dr Hilary Cass hitting the headlines again in response to the puberty blocker trial that she recommended that everyone's talking about, I thought it would be a good time to go back to this interview that she gave with Dr Abbasi, Editor-in-Chief of the British Medical Journal.
Hello and welcome. I'm here today with Dr Hilary Cass, who's chaired an independent review into gender identity in children and young people.
Some people are questioning whether this really was an independent review and whether Dr Cass was actually the right person to carry it out. Did she have experience in carrying out such a high-powered review, such an important outcome? And was she truly independent? Was there some kind of narrative, which is what some people are saying, that she had already predetermined the outcome that she wanted to achieve?
Yes, so I'm a paediatrician. My clinical specialty was in children with disability.
You know, it's very unusual in medicine for somebody to carry out a review on a different specialty, one that's not your own. So Dr Cass, her clinical specialty is in children with disability, but this is a review on children with gender incongruence. They don't have a disability. It's a bit like you wouldn't ask a heart surgeon to carry out a review of a brain surgeon's work. It just doesn't work like that. You don't ask a respiratory physician, a lung physician, to carry out a review on, for example, diabetes. You would ask someone who is in that specialty. It's a very strange decision to have made.
We tried to make this as wide-ranging and multidimensional as possible. And quite clearly, the absolute starting point had to be looking at the evidence.
I wonder what she means by wide-ranging and multidimensional, because there are some people who are saying she didn't ask the true experts. There are many experts in the Endocrine Society and in WPATH who are saying she didn't ask me. There are also many people saying she did ask me, but she didn't listen to what I said, and particularly those from the trans community themselves, the parents and families of transgender people and transgender young people. Were they interviewed and were they listened to? Were their opinions taken into account? And then the absolute starting point has to be looking at the evidence, for sure. But actually that evidence has already been looked at many, many times. And most recently in the WPATH Standards of Care 8, every single tiny weeny piece of research was looked at in great detail. So I'm just wondering why Dr Cass came to a different outcome than the world experts.
Children and young people have just been really poorly served by what's happened over the last, numbers of months and years, really.
Now, I agree, they have been poorly served. But why is that? Now, we know that the Tavistock clinic got closed down, and it got closed down for many different reasons. They weren't operating to international clinical standards. They had their own protocols. They weren't collecting data. They didn't stick to their trial. So yes, I agree, children and young people have been poorly served in the UK, but for different reasons than Dr Cass then went on to make her recommendations.
They're a very complex group of young people, or a group with complex presentations, and many of them have neurodiversity or other mental health problems.
We hear this a lot, don't we? A very complex group of young people, or as she goes on to qualify, a group with complex presentations. Transgender people, transgender young people, transgender adults don't necessarily have to be complex. It becomes complex when people are not listening and hearing and understanding, and that causes issues. Just because you are transgender does not make you complex. It's the difficulties that transgender people face that cause the complexities and cause these complex presentations. Many of them have neurodiversity or other mental health problems. Now, this is always being brought up, the neurodiversity thing. There is overlap. People who are neurodiverse may find it difficult in social situations. Transgender people who have been not believed, not listened to, not accepted, not heard, had no place in society may also face difficulties in social situations. And it's very difficult to make sure that we're not saying that all trans people are neurodiverse. Sure, some will be. And sure, people who are neurodiverse may share some similar attributes to people who have faced difficulties with their gender identity. But we must not use this as an exclusion point. We must not make it so that people who are neurodiverse are excluded from being believed that they are transgender. And the mental health problems, I've got a very, very good idea. If you just accept trans people for who they are, listen to them and believe them and provide them with the care that they need, they don't end up having mental health problems.
Medical intervention has kind of taken over. People have not really looked in a systematic way about how psychological therapies can be used for this group.
You see, this really worries me, how psychological therapies can be used for this group. There's only one way psychological therapy should be used for trans people, and that's to help support them live their best life, to help them through difficulties that they might be facing or have faced. This is not about using psychological therapies to get rid of gender incongruence. You can't.
I think what's very important is that you don't make those decisions in a state of mental distress.
We've seen this point many times. People who are too mentally distressed to qualify for treatment. I told you before, the mental distress arises from exclusion, disbelief, non-acceptance, poor access to care. That's what causes the mental distress. And then when you actually get to the end of the queue, you're so mentally distressed that they stop you getting care in the first place. It's just ridiculous.
From my point of view, it's really important that everybody who walks through the door of the clinic is in some kind of research programme.
Do you know, I agree, we need research. In every area of medicine, we need research. But this point of consent has to be from the patient. You can't say you can't have treatment unless you join a research programme. That is just not how medical ethics works.
So a young person may, for example, have depression or an eating disorder and they've got gender dysphoria. It may be that the depression has resulted in their gender-related distress.
Depression doesn't cause gender incongruence. And I know Dr. Cass finds it very difficult to say the words transgender or the official medical diagnosis as used by the World Health Organization, gender incongruence. But depression doesn't cause gender-related distress. Ignoring people, not helping people, not believing people, not caring for people who are transgender causes depression in those people. But this view that depression has resulted in their gender-related distress is just nonsense.
Or they've had a trauma, and these young people have high levels of adverse childhood experiences, and it may be that addressing that, their gender distress may resolve.
So this is another thing that Dr. Cass uses a lot. This idea that children who have had previous trauma may now be exhibiting gender-related distress. Now, yes, it's true that trans children are experiencing trauma, but it's not trauma from childhood experiences that causes gender incongruence, being transgender, gender-related distress.
So this is a group of young people who do have a higher suicide risk than the general population.
For sure. Thank you, Dr. Cass, for highlighting that problem. And that's the problem we need to solve. But the difficulty is withdrawing their care is not going to help their suicidality. We know that. Research has shown us that very clearly. If you support young people in their gender identity, give them the care that they need, give them the acceptance, the belief, the support that they need, their mental health gets better.
The only thing that we can tangibly say is that particularly for the birth-registered males, if you stop them breaking their voice and growing facial hair, then they may pass better in adulthood.
Such a sweeping statement. Birth-registered males, so she can't even say trans females. If you stop them breaking their voice and growing facial hair, they may pass better in adulthood. Pass better than who? It's such a scathing way to talk about the difficulties, the life-changing, permanent developments that happen during puberty. And it's not just trans females that have this distress.
The point is that it is not the intent of the psychological treatment to change their gender perception. It may happen during the course of treatment.
Another issue that's
Okay, so not enough assessment, not enough care, not getting treatments, not enough evidence, so let's stop the lot, is it? So, and that's what's happened. It's absolutely shocking. And it's trans young people that are really suffering from this. On the other hand, she does say something that I agree with here.
I think we've all let young people down.
We've all let young people down, including Dr. Cass.